call this meeting. I got it. Call this meeting to order. I guess does everybody know each other?
No.
Okay. Well, I'm Billy Kennedy. I'm from Watauga County. I'm the county commissioner there, and I've just come back on the Smoky Mountain board. Yeah. Billy Kennedy. Hi, Jeff. Nice to meet you. Thanks.
And I'm Pat McGinnis, and I'm from McDowell County. Yvonne Frank, I'm the team liaison to Smoky.
Julie Sinclair, Senior Director, Quality and Integrity Operations.
Michael Lavender from McDowell County. And Smoky.
Jeff Heck, the CEO of MEDICAID.
Oh, I'm sorry, Mary Short. I didn't think I was going to introduce myself. Mary Short and Katie.
And I'm Ray Ratliff. I'm an executive assistant here, and I'm the recorder today.
Nice to meet you, Ray. Well, this is my first meeting and of this committee, and I've somehow got myself as chair, so we'll hopefully get through it with Julie's help and direction. So I guess we'll need a motion to approve the agenda first.
I'll make a motion to approve the agenda.
Do we have a second?
Second.
Seconds. And I guess we need a motion to approve the minutes from last month's meeting, and I wasn't present at it, so if somebody else can make that motion too.
So moved.
I'll second. I was there.
And one thing, there is not public comment at this committee meeting. I just wanted to let people know. So we're done with that, and I guess if we get a vote on that, I guess we're all in favor of approving the minutes. Sorry about that. And I guess we'll go on to monthly reports.
Okay, so as Mary so kindly pointed out, I actually put item numbers to relate to the agenda, and I did actually put page numbers as well, so that we can, if we jump from place to place, we can at least have a reference. The first thing that we're going to look at is, I'm going to go into a little more detail about these since it's Billy's first meeting. You guys know what we're looking at, but this is a Smoky Performance Improvement Grid. It is not it's an internal grid where we track all of the items that we want, where we want to make improvements. So they relate to our measures. So for instance, on page 1 of D1, you'll see a green line that says Access to Care Report. So we turn in a quarterly Access to Care Report, and our measures are below standard. And so we keep an internal tracking of this so that we can work with customer services in creating goals to improve.
And the state standard is arbitrarily set. It's not the average.
It is actually the average from the last fiscal year.
Okay. Okay. So there was because some of these were not up to the state standard.
Well, no, we're not. But another issue with this particular Access to Care report is you have different LME MCOs reporting it differently.
Okay.
And they're self-reporting, and so the state is obligated to take the self-report of LME MCOs
Which is what this is from Smoky. And you're just saying they're not all synchronous. I mean, they're not all going by the same criteria.
Even though there are definitions, but people interpret definitions differently.
Yes.
So I usually just let the members look at this and see if they have any questions and report on any new items. We do have 2 new items on this, but they're at the end, so if anyone has any.
And I guess the first thing is finding the need, and you've worked on that criteria for what the services are and evaluating them. And then the corrective action, and then updated in the policy manual, and then
It's updated here Oh, you mean for EQR? Actually, what page are you on?
Well, I jumped ahead, but I noticed, I guess some of them have the corrective action in them.
Yes.
And then in the update summary, you've got the policy manual. And it's
Right,
been
it's where we
changed.
changed it, yes.
And then I assume that the service providers would be made aware of all that, or
Right, we
this is still
updated,
inside?
we are in the process of updating the provider operations manual and the consumer and family handbook.
And that's where these updated policies go.
The policies don't actually go in there, but they correlate because some of them are internal policies,
Okay.
so.
One of these is really kind of low on page 3 at the bottom. Is it still that low, or are we doing any better? 49%, 36% on the updated?
We're doing a lot better. We have a corrective action plan that has us, I would get it from Renee, but it's much higher. We'll know when the new report comes out.
And that was mainly the data storage and privacy issues, isn't that what that's?
Actually, no, these, we didn't get a quarterly report, we got a letter. So if you see over here in the update summary, on the bottom of page 3, we didn't get a report, we got a memo from the director of DMH DDSAS that's saying what standards we met. And so we met this standard. Once we meet it, as we keep things on here, Billy, for 6 months when we meet the standard, and after we've met the standard for 6 months, we take them off here because we want to continue to track them.
Okay, so then you can assume it's been met if it's.
When we take it off. So we got this memo in April. So we'll wait for the July memo about the next quarter, and if we meet it 2 quarters in a row, that's 6 months, we'll take these off.
And 6 months kind of gives you time to see if things are changing.
If we're holding, have a pattern of holding.
Thank you.
And if you look on page 5 under external quality review, corrective action items, after this was printed, we got our update, and a lot of these items have been corrected. I think we have about 8 items still outstanding. So I know that 1 through 5, like 1 and 2 on page 5 were corrected, and on page 6, 3 through 5 were corrected.
And is that what the updated policy means, that it's been corrected, or is
Yes.
there some other way that you find you know that? Are you just telling us?
I'm just telling you.
Gotcha. Okay, thanks.
Julie, remind me on some of these quantifiable objective measures, like particularly on page 3 and 4. I'm assuming it's some kind of convenience sample, or a random sample of some sort. It's not all. That's not every record, is it? There must be some sample.
No, for these it's all the records
It is all the records?
because it's automated, and
Okay.
they can just pull the
Okay.
data.
Okay.
So like on page 4 where it says second quarter chief standard, that 70 is really, we got up to the 90.
Yes.
Okay, but since that was after this was prepared or something?
No, it's just that we didn't get a numerical figure. We just got a letter that we met the
Gotcha.
standard, so we didn't
Okay.
get the measures.
So even if these numbers are low and it says achieve standard, then those standards have been.
Right, under this SMC performance, that is when we went out of compliance. So that will stay the same under SMC performance, and then the updates, the last column, will have the updated measures.
And there was all dates, okay, I see. Thanks.
So on page didn't cut off the last page, I'll bring that next time. When we did our innovations quarterly report, there were 2 of the 28 measures that we did not achieve what we wanted to, and so we need to put them on here. And I don't remember exactly which ones those were, but I will bring them next time. I think the problem is that when we added them, we didn't change the print range, and so it didn't print those 2 rows.
So you'll just bring those to us next meeting?
So they would be like 39 and 40? Is that what you're talking about?
No, they would be not 39 and 40, they would be a different category. So they would be 1 and 2 in a different category.
Really, the only thing on this that's not been met now are pages 1 and 2, right?
Yes.
That's good.
So one other just broad question, says, 15 pages of this. Are there any of these items that created heartburn for the staff, or, looked at it and said, wow, this is something we got to address right away? Was there anything there that was particularly alarming?
The access to care.
Access to care.
I mean, it's very troubling to us. The way it's measured and the fact that we're not meeting it. The unfortunate thing that you know really well is that people don't always keep appointments.
Right.
However, we are responsible, or those numbers go into our ability to get them access to care. The fact that we scheduled an appointment doesn't count. They have to keep the appointment. And if they don't keep it because of their own volition, it counts against us.
So it's still considered a no-show, or is considered?
In our inability
Your
to
inability.
obtain access to care,
Yeah.
yes.
And you break that down separate from,
It's included in the measure.
so it's hard to gauge where.
On the page 8, on the first sentence on the bottom block, it's Consumer and Family Advisory Committee, not Consumer and Family Action Committee. I need to correct that. See,
Oh, that, yes, we do know that, but that is not our wording. This is the wording that came from the Carolina Center for Medical Excellence. That's actually what they wrote in their findings, so we wrote it verbatim. And yes,
well,
where we write it, what I can do is just,
well, we'd like them to know who CFAC is.
yes.
And the proper wording, so.
Yes, that is a little disconcerting in that they've been dealing
So
with
this is who that wrote this?
Carolina's Center for Medical Excellence.
The access to care, the reality is, these aren't our numbers, these are our providers' numbers, right?
Well, it's our responsibility to schedule appointments within certain time frames. We are well within the scheduling the appointments. It's the not showing up. And industry standard is about, I'm thinking it's in the 50s, the show rate, right? The no-show rate is almost 50% for behavioral health care, I think. Yeah.
I mean, I think in our most challenging practices in Mayhew is our OB practices, which we have a no-show rate of 16%. And that's considered fully unacceptable from our standpoint because of the critical nature of the visits, probably comparable to what you'd have in behavioral health, so 50%.
Yeah, it's. I mean, for as long as I've worked in behavioral health, that's been about the average. I mean, I worked on a project for my own practice and got it up to 68% show rate, but that was calling people and calling them.
So do you have, I mean, I'm assuming you, like when you really break this out and you look at which is no-show.
And this is initial appointments. It's not all show rate. It's initial
This
appointments.
is just the initial appointments too. That's what I was wondering about.
So that's why the show rate is a little.
Yeah, so you could, I'm assuming you have the data to show which are the people that didn't have an appointment because of inability to schedule it versus those who just didn't come. And I would assume that your ability to get them an appointment is in the 98, 99%.
Yes.
And then you deal with this. I mean, it's not that, I mean, I would agree that there should be heartburn about it just because, you know, in the old days, if the view was if they didn't show up, well, you know, tough luck, you know, that's your responsibility to show up. But I think that's not the case anymore. And I agree that, you know, we should be making all efforts to try to get them in. But
Right, but this is a measure that's used to assess our effectiveness as an MCO at
Yeah,
the state level.
yeah,
And that's why it's so concerning, because we know what we're doing and not saying anything you don't know.
Now, so if I can, just to piggyback on some of what Julie is saying, in this first quarter of this year, actually, we did do some collaborative calls with the LME MCOs around this measure, because there was clear evidence that LMEs were interpreting and reporting differently, and it is a very important measure, and we want standardization. We are hoping there were some changes made, and into how to define them, and there are still a few bugs to work out. But we're hoping that in the latter quarters of this calendar year that we should see some more standardization. And if that does happen, we're actually anticipating the average to drop.
yeah, so the gold standard
so
will
that
change.
it will be more accurate, right?
Right.
And so that I mean, for emergent, of course, emergent is always,
Right.
we'd
like
should be
100%.
high.
Yes.
Absolutely.
Right.
But so that it's a more accurate number in comparison between the MCOs. So that's the intent in the whole.
Yeah.
Now, most of these cases are referred, right? Or do they, I mean, this first time visit, some would be an IVC?
No,
So,
but they might be, they might have been committed to a hospital, and that's their introduction to the system, and the hospital calls for an appointment, and we're required to have them seen within a certain time frame of their discharge.
And then, so the hospital, this person's, I mean, I know they're not in the hospital very long in our state, it's 5 days or something. So, how does this person, I guess they tell the person this is your appointment, you need to go to it. But, and then we do a follow-up call and stuff
We
too?
do reminder calls and follow-up calls. That's how we know people who've kept appointments, the numbers who've kept appointments and who haven't.
And is texting and email prevalent in this client group?
We're exploring that. There are certain security risks associated with texting.
And HIPAA violations if you don't have encrypted messaging.
Okay, I just noticed some of my dentist is doing that, but I guess that's a different thing there, so, okay.
Yeah. What's interesting is that it's fairly common for people to do texting using unencrypted messaging, but it is a HIPAA violation.
Okay, well, we don't want to do that.
We do not. Any other questions about this?
Do we know, for example, if this is an aggregate of all of our clinicians, but do we have it broken down, for example, as a provider in the central region doing better than the provider in the western region versus the northern region? You see what I'm saying?
Yes, but we don't.
We don't have the data, or we don't see a difference.
We don't, I mean, we haven't looked at it that way.
I mean, it just seems to me, if we want to drill down and see, is one doing it better than another, that could tell us, you know.
But it's not a matter of the providers, because we set our own internal standards tighter than the state standards. So where the state standards say we have 14 days to get a routine appointment, our internal standards are 7 days, and we are able to get those appointments. We are always able to get those appointments.
Right,
But
what I guess I'm talking about is the no-show part of it.
yeah, I don't know. We haven't looked at it.
And I wonder if an urban versus rural factor is in there too, as far as transportation.
Is huge.
Because I
Huge
know
barrier.
we've got, in our county, it's a significant issue for people that the low income can't afford to get it, and they're charging for
Actually, you
public
know what,
transportation now,
you know
so.
what, Michael? This, when we go to the access to care report, there is county data.
Just,
It's not here, and the state doesn't look at it, but there is. We'll look at it in a little while.
yeah, I guess because I'm thinking, for example, if you saw that the primary provider in the central region, I'll just use, since that's where I'm at as an example, is having a smaller no-show rate, then is the issue that you're getting them that 14-day appointment sooner, or is the issue that they're making calls where another one isn't? You see what I'm saying?
We are making the calls. We make, our customer service staff make all the reminder calls. They may also do it, but we do it as well, because it's our measure.
And you're saying this 50% is kind of what you think is the national average for the behavioral?
Behavioral health. I heard that in a meeting just the other day. I don't know who told me.
And it makes sense because, I mean, without, in some of the time, the care provider's not getting to the appointment, they're not going to, I mean, whoever's with them.
Well, and the nature of the illness,
Yeah.
for mental health and substance abuse,
Okay.
unless you're engaged in treatment, when you're initially accessing treatment, if you access it in crisis, which is usually more than 50% of the people come into the system through crisis, then if you feel better, you're not as inclined to go to your follow-up appointment.
And money shouldn't be affecting these appointments.
No.
Do they have co-pays? And
No.
so it's not, I mean, the transportation costs may affect it, but they're not coming because they can't afford to come to the...
But if they're new, do they know that they don't have to have money?
They would be told by the customer services.
Okay. Well, if you do think of, some other metrics we could look at on that, like Michael said, to drill down and see whether it's providers or where as good is this going to be, and
Yeah.
then you have to think outside the box, and how do you get them to those appointments, and that, Smokey can't go out and afford to go out and pick them up and bring them in.
Okay, I wrote that down, and I'll talk to my data person and see if we can do that.
Although when there's standardization of data, we might see a totally different view. We might look like the best there is.
Right.
There
right.
is, I mean, yes, one of the standardization of definitions and how people are told to do things doesn't necessarily mean they do them that way.
We're getting right down to the nature of man now.
Yeah. It impacts self-reporting. Just say that. I already know people are changing things and not doing it the way they're told to, so.
Sorry about that.
That's unfortunate. We try to be really accurate. We don't gain anything by being inaccurate, because if we don't document accurate data, and then we have nothing
Yep.
stable to compare it with. Any growth isn't
Yeah.
true growth.
Yeah.
The only culture of learning that you can create is one which is open and honest and right.
Now, this is a way that we could, in a roundabout way, find some of those people that are not doing the procedures in a way. Because if we get more complaints,
It has to do with outside of our catchment area, though.
that standard, yeah. Okay.
That's the LMEMs, other LMMCOs.
Yeah.
And not necessarily reporting data the way they've been instructed.
Right. But I mean, that taking our data from our providers is somewhat of an act of faith, too.
This is not data that comes from providers. All this data that we report is our own.
Okay.
So, the one thing just to mention is one of the projects that we have currently going on between a multitude of organizations. Smokey's right in the middle of it, is a project where we actually recognize that there are some patients at high risk who are frequent visitors to the ED and the hospital. And those patients are actually, if they don't show up for their appointment, not only do they get a phone call, but if necessary, somebody to come out to their home and visit. And in some cases have been literally on the streets. They've gone to where the homeless population is, pick them up and bring them for their appointment or provide services for them. So it's a very different way. It's an acknowledgement that actually some people really don't have the capacity to actually look after themselves and take that responsibility, or they're really limited by transportation in a way that makes it impossible for them to do it. So we'll see. We're collecting lots of data on this, but it'll be very interesting to see what the outcome is. It's a totally different way of looking at how to manage these most complex patients. And they have, and the reason I'm talking about is because MEDIC's involved for the physical component of it, and so we're actually, they may have a nurse practitioner and a psychiatric care manager or caseworker actually with them. That's pretty novel.
And who's paying for that?
Oh, a bunch of people. It's one of
Is
those.
this the one with Mayhack and other
Yeah,
stuff too? Okay.
it's Mayhack, it's Mission, it's Smoky, it's the county. We're even using some funding from the UNC School of Medicine, where we have medical students actually participating in some of that.
Oh, good.
So it's
Is that just in this county, or is it?
it's just in this case, just really focused on a population that comes in and out of Mission Hospital. But it's not that it could be replicable in other areas, just depending on the capacity to do it and the need, and of course ultimately is whether it works really or not. And so far it's been extraordinarily effective and saves money.
Yeah, because even though Watauga's numbers are so much lower, we still have repeat clients at the hospital, and then the sheriff's going out to deal with the situation, which is and until they get in the program. But I was thinking once they're this is just initial
Yes.
visit. After that, if they're mandated or something, then they're going to get them to the appointment, or they will pay consequences. I guess on the substance abuse side more than.
It seems like, potential would exist for, applying for like community foundation grants or other grant type sources that maybe could help you pay for vans, for example, to transport clients, and then piggybacking with the DSSs, for example, to see if you could collaborate on the manpower side of it to,
There are county DSSs and some public health. There is a county transportation system for medical appointments, for Medicaid appointments, for Medicaid consumers. The problem with those services is they have to be scheduled so far in advance. If we are able to get appointments in 2 days or 4 days, people can't use those services.
Which is when they need them.
Right.
But I guess what I'm saying is that, probably that scheduling far in advance is partly because they don't have the vans or the
Correct.
staff.
Mhm.
So if we could get external sources to help us pay for some vans, if you could get the counties or the, public health or whomever to help you with staffing, then those long appointment times could become short, you know what I'm saying? But it would require partnership somehow.
And
Well,
money.
and I don't know if all the counties have, like we have Apple Park, which is mainly ASU, and that provides a lot of public transportation that our neighboring counties don't have as much either. So that's a good idea, Michael, if we could increase that getting people. If that's part of the reason they're not getting there.
Well, the project that we have, actually, we do have vans that we can use, and it makes all the difference. But ultimately, it's a whole different way of looking at how you pay for it. So this is off subject, but there's 200 people in that project. Last year, in the same calendar year, they spent $1 million on healthcare, aggregated healthcare altogether, than they had this year. It just comes from savings from the ED visits and the hospitalizations, which go up quickly. So $1 million in for 200 patients, that makes a big difference. And there is, you know, once you have the system in place and you know how to work it well, it could be replicable in many places.
I think it's a great idea. And you know, the other side of that is just what you said. If you're providing the shorter term care, the longer term stuff. Well, maybe I said that wrong. But in other words, taking care of the crisis while it's happening is going to save you in the long run. I'm not saying that way. I'm sorry.
But getting to the financing part of it, you say like it's the organizations that are doing it are not necessarily going to benefit financially. So that gets to the big picture of, okay, we're reducing cost,
Right.
but these vans are not getting the revenue to pay for the vans.
Right.
But in the overall picture, we've reduced $1 million of cost by doing this program for,
Yeah.
say, 100,000 or whatever.
Right, right. So then it makes it more. It's the only mechanism which you can could actually say to the state, let's do this very differently.
Yeah.
I mean, it's one of the reasons why Smokey and Mayheck and others are really interested in the 1115 waiver, because under a waiver you can actually spend money differently. So we're hoping that ultimately comes about, or some form thereof.
And if this y'all are dating, compiling data on this project, I guess.
Oh, yeah.
So it'll
Yeah, we are.
show that it's worth investing in.
Yeah, yeah.
And I still think there's probably a rural-urban, just the numbers
Yes.
there.
Right.
But still, getting that one person in Watauga is just as important as getting those 200 people in here in Bunbury.
Right.
So.
Right.
I see a big change since there's, when on Foothills, they had state vehicles, of course, there was providers too. As far as getting consumers to the table at a variety of things, not only treatment, but even to serve on committees and stuff, they're not getting there anymore.
Yeah.
The vast majority of them, because years ago, staff went and picked them up. Staff don't have any vehicles to go pick them up in now.
Yeah.
Probably need to move ahead.
Moving right along, sorry, thank you, Julie. That was very informative to me. I'm glad we delved into that a little bit. It's helped me anyhow.
The next document that we review is our monthly DHHS monitoring report. It includes both DMA and DMH measures. But we have 3 documents: an executive summary, the data sheet, and then the trends that are for the past year. In April, we met all of our standards, so there's really nothing too remarkable about this, unless you have questions.
It says on here on the summary that, that's since,
The trends,
trends is saying that the denied for clinical reasons is trending sharply up. But if I'm looking at this data right, there's only one authorized request denied for clinical reasons.
are you
It
on
looks
the,
like it's trending down. It's on page 4, the bottom.
so that's state funded,
Maybe that's,
and if you go to page
okay,
3,
that's why I didn't see the data.
it's the 3rd line down.
Yeah, I'm sorry.
That's okay.
That's where I was messing up. I was looking at the wrong. Yeah, okay, I see it now. So when it's saying denied for clinical reasons, does that mean that folks reporting it are not reporting it accurately, or that that particular clinical reason wouldn't get authorized?
What it means is that when the provider submitted the request for services, they did not submit evidence, documented evidence that the person that they're requesting services for meets medical necessity as defined in the service.
And who is usually doing that initial evaluation? Is it the providers, or is it DSS, or is it
Well, the
hospital? Or?
providers submit requests for services, or they're providing services, and we do the authorization review. So we have licensed clinicians who have experience in the population, so we would not have somebody who is licensed in only mental health, only has mental health experience. They would not review a substance abuse request. And somebody who has experience with only adults would not be reviewing a child request.
So, yes, I think I understand that. So, but we don't really know. So, are you, to get back to Michael's question, you think, can we tell whether some of these were by the definition of clinical needs being not fitting their needs, or by the reporting? I mean, you're saying sometimes the providers don't.
We don't actually know whether the provider didn't put everything they needed to in the request, or whether they interpret the service differently. But regardless of what is submitted on paper is not evidencing a need for the service, and that's why it would be denied.
And then does Smokey go back to that provider on those denied and look into them or question? I mean,
for Medicaid, the law requires us to inform the consumer, and the consumer has appeal rights.
okay.
So we write a letter to the consumer, and the provider can go into the Alpha system and see the reason. We put a justification, a very clear what wasn't met.
Okay.
So
if it's something they just forgot to put in, they should catch it at that point and get that person in.
Who helps the consumer if they're not capable of?
they're allowed to have a representative. Sometimes the providers do, sometimes they have someone else help them. They're allowed to identify a representative, but by law, we are required to notify the consumer.
Is there like, I know the Guardian ad litem program for people in the judicial system. Is there a similar program in mental health?
No, but that's a great idea.
You know, you pair up somebody who sticks with the person all through the process, and I think most of them, I guess some of them paid, I don't know if they're volunteer paid, I don't know.
Mostly volunteer.
Yeah.
But they're, yes. I think those volunteers I've seen some really, really good Guardian ad
Oh,
lites.
yeah. And they deal with, they see it from the beginning to the,
They
all the
have
way
that
through.
child's interest at heart.
Right. Anything else you want to?
No, there's not a lot to highlight on this. We're meeting the standards. That's the good news. We've been meeting the standards for a period of, I think, over 6 months, all the standards, so that's good.
And I guess some of the grievances would come from people, I mean, if they were denied service, that would come up and they appealed, would that show up as a grievance?
No, that's, a grievance is anything other than an expression of dissatisfaction about an action. However, if they didn't like the way we handled their appeal, they could grieve against us.
Okay. So that wouldn't show up in the grievance?
No, not the appeals. The appeals show up in the, actually, let me see, it's in this trend report, if you put it in the slides. No, he didn't trend that, but it is in here. On page 3, in that top section, you can see the number of consumer authorizations.
Appeals
Appeals
received.
received.
I guess, yeah. And that seems
Page 3 of the slides.
Page 3 of the data.
of D2B.
would be 3.
That's good. And it's actually gone down in the last 2 months, so, but.
What it is, actually, it's gone down in the last year. If you were to look at this a year ago, it would have been a lot higher. We've been doing a performance improvement project to make the letters more readable to consumers, not use such technical clinical language and explain it more clearly. And since people are better able to understand the reason that their service is being turned down, then they know how to adjust the request of the provider, or so that's been really one of our most successful performance improvement projects that we've been able to see the results.
And that's just been in the last year or 2?
Year.
Okay. So really these, as far as going back, this goes pretty much to when Western Highlands came, I mean, close to it. I mean, I know that we're having to look for trends and stuff. You really have to start from when Smokey was doing all 323 counties. So we'll be getting more of a trend as we go forward.
We can, but as you see, it ends June 2015. The state will give us a new template that'll probably go back to January 2015. So we'll have those green columns filled in because they're from the last fiscal year, and then we'll start filling in the other columns. So
Okay.
It'll look shorter, but we can pull the historical data whenever. This committee's made several requests, and we've pulled the whatever data. You know, Dr. Heck made a request, and we try to put a priority on board requests for data.
Okay, thank you.
How long does a provider fraud and abuse case normally take?
A long time,
Months, years?
sometimes a month, sometimes months.
Okay, so quarterly reports?
Okay, we have our grievance report, which is D3A.
Looks like things are trending down, that's good.
I don't know what kind of questions you have about this. They are trending down. We are continuing to resolve them in a timely manner.
Is it any kind of seasonal peak?
Not for grievances.
Okay.
Looks like you're referring a few more for investigation than previously, but it could just be a temporary.
What page are you on?
Bottom of page 5.
Okay. Yes. I don't know necessarily that we are reporting more for investigation, but we are getting much better in our reporting, in our data collection. So since Andrew has started working with the grievance team on the data, Andrew is our program integrity data analyst, then we're capturing things better. But we are also training our staff in what's an investigatable grievance versus not.
Has that definition changed, or it's always been about, so it's just...
But you used to have people thinking of resolving the grievance, and now you have people thinking of bigger systems issues. So not only is it my responsibility to the individual to resolve the grievance, it's my responsibility to other individuals in the system that if the grievance shows a red flag for a systemic problem with the provider, it's my responsibility to refer it for more detailed investigation.
So to be safe, they might, if in doubt, might be want to push it towards investigation instead of not, or not necessarily?
No, there are pretty significant issues. For example, a recent issue was that one of the recent grievances was from an AFL provider, which is an alternative family living situation. So that was complaining that the provider agency for whom they worked was withholding money from their pay because they didn't give receipts for spending on a consumer. And there are very tight requirements about consumer funds and how you have to account for the spending of their monies. So we found out that actually that AFL provider wasn't doing their job. If that had been like a group home and there were more people than one in that placement, we would have done a bigger investigation to look at all the consumer funds instead of just that one person's consumer funds. So that's the kind of thing that would be referred.
But the consumer would be now getting receipts and they would be being more accountable in dealing with the consumer.
And you know, that receipts for the money out has, I mean, that's the, you can't cook it.
You just don't.
That's one of the basics you gotta do, so.
Right, don't mess, that's just, you don't. So we have, I don't know what questions you have about the data.
This grievance disability by type on page 6, is that for trending? I mean, what?
Those are the
just-
different quarters.
just Information.
So it's 6 months worth of trending.
And it seems like it jumps all around month to month, so there's hard to plan. I
Things
guess.
like this, you really have to look at like a rolling 12-month line to see if there's a trend. You know,
Considering
your
the volume.
77, that is an outlier.
When you consider the volume of services provided, you know, it would be easy for a large variation just because, just the number itself.
Mm-hmm.
Yeah.
Yes.
It's good.
So we're doing well there. I guess we can go on to the incident report summary.
Yeah, sounds good.
You know, one thing, just thing, I'm sorry,
No.
we tend to drag this out. When you're reporting by counties, the hard thing for me always to figure out is you're reporting by the raw numbers rather than the numbers per recipient or, you know, or population. It's just hard to know. Like it would be helpful to be able to look at a county and say, wow, you know, there's a threefold difference there between, you know, Clay County and Henderson County, even when they have different population.
One of the things that would skew that,
The last 10 or 11.
and Michael will be able, I know that Michael talks about this sometimes. Some counties have more facilities. So if I might in one county, McDowell, have a fewer number of Medicaid eligibles, but a greater number of Medicaid recipients because I have a lot of group homes in that county.
Yeah. Mm-hmm.
And so it really needs to be by consumers who are served in that county.
Right.
However, those people who are served in those group homes in those counties have their Medicaid counties of origin, not McDowell.
Right, yeah, that's what I think you're exactly right. So rather than, the thing it's hard for me to look at is just the
Yes.
raw numbers. But if it was percentage of consumers served, that would be best. I would agree with you.
Right, and we don't even know
Regardless of what county
that
they
we can
actually
get
come
that.
from.
Right. And I actually am not a fan of raw numbers in a report.
Yeah, I mean, you can't be strategic in your thinking about it. So
Because you could look, and if you didn't know, you'd say, gosh,
Fucking screwed up.
yeah. Yes,
Not that they haven't, but.
okay, so we go to our incident report summary. These incidents are required, levels 2 and 3 are required to be reported to us. We track them, we trend them, we may investigate them. We're pretty stable in these numbers. A
And
few additional level 3s.
jails are not included in this.
No. They're not considered providers.
Remind me what problematic behavior.
If you look at the end, let me see, there, okay. The last, let's see, pages 6 and 7 have your definitions, telling you what your level 2s and 3s are. Except I don't see problematic behavior here. I'll talk to Tasha and have her put it on. So, problematic behavior might be if I am in a group home and we go on an outing and we go to a store to learn how to shop and I knock over a display of potato chips.
That's a client issue, right? Whereas most of these,
The problems that would be potential provider issues are medication errors,
restrictive intervention,
allegation, yeah,
even suspension, expulsion, the injury, they all seem to be related to the provider, but problematic behavior seems to be client-focused unless I'm...
This is all client-focused. There are guidelines regarding what you have to report as an incident, and it's really anything outside what you would normally expect. It's actually right here. Circumstance inconsistent with routine operation.
That's problematic behavior. Is that what you're saying?
That problematic behavior is, okay, so if I'm an outpatient therapist and somebody threatens suicide in my office and they're a pretty stable person, I'd be more inclined to file an incident report than a mobile crisis who's responding to a suicidal threat.
Right.
So it's expected that in crisis, that's routine, responding to suicidal ideation or gestures is routine in mobile crisis, but it's not in outpatient therapy. So it's different by provider type.
Can you read the definition again?
A circumstance inconsistent with the routine operation of a facility, consumer care, or service, which leads to adverse effects upon a consumer.
So that could be just disruptive.
I guess that's still, even that definition, inconsistent with routine operation, and then which leads to adverse effects upon a consumer. So I was trying to figure out if the problematic behavior is employee problematic behavior, or
No,
if it's a client.
it's client.
Well, to the client, sometimes it might be employee
That's an
behavior.
allegation.
Uh,
That's listed as an allegation.
But, I mean, they may do things differently than the staff views things. Very differently.
Right.
And hopefully in the allegation or that would be addressed. You're saying under
That's
the-
why these are all turned in to the LME MCO and we review every one of them. And those items that are level 3, we send to the critical incident committee, review committee, and that has it has probably 4, senior clinicians and 2 other clinicians in the agency, and review all of those. And we look for, did the provider handle the incident appropriately? Did the provider miss anything antecedent to the incident that they should have done to prevent the incident? And in cases where we have a trend or we see a trend of problems occurring with the same provider multiple times, we will refer them for an investigation. But we request the clinical records, we review them. So that's how we ensure that what is reported is what actually happened and how it was dealt with was appropriate.
And has Smokey let some providers go over the years?
Yeah.
We have, but not solely based on an incident report.
No, I didn't say why, just that when
Yes.
they're not, whatever is not working, they
We have a clear selection and retention policy for our network.
I mean, to me, the number of medication errors seems relatively high. I don't know how you, are those also split into different types of serious consequences? Because like in the hospital, we'll talk about a potential sentinel event or a sentinel event itself.
Right, they are split here into, but I don't know, we haven't tracked them.
Mm-hmm.
But if I refuse to take my medicine,
yeah.
it's counted as a medication error.
Yeah, okay, so like refusal or missed a dose is really different than wrong dose, wrong medication, wrong recipient, preparation error. So.
And the loss of spillage, I guess it depends on who's administering the medication, I guess.
Well, I mean, there's always, medications are variable.
These medications in our facilities are self-administered with oversight.
Okay. So we
So
don't have a
if-
breakdown between the wrong dosage and the refusal that would go to the provider versus the client.
I've only seen one of those. It came up to a level 3. I'm on the critical incident. I've only seen one of those.
Of
The
medical.
ones that has been a
Okay.
grave error.
So that's quite rare, you say.
Mhm.
Okay. Well, anything else?
Okay, the next item is the access to care quarterly report, but because we spent so much time on that, did you have another question about it?
Yeah, I was just going to ask, in level 3, look at the front page, it says there, level 3, 31 in April, 29 in March, as an example. When you go over here to the review committee incidents by type, if you count across in April, 10, 17, 19,
That's
versus
because,
31,
right,
whereas in March there's 25 versus 29.
because levels, deaths skew the levels. All deaths come in as a level 3. However, if you look on the last page, or the second to last page, natural causes and terminal illness are actually a level 2 death. However, until we get the ME report, they're classified as a level 3 death. And so numbers change.
After the autopsy is performed, I guess.
Right, when we get
If
the
there is
medical
an autopsy.
exam. So if we get something in and the provider said, we read this in the obituaries, and we called the family and it said they died from a heart attack, and then we get the ME report and it was an overdose, it could change the cause of death and then change the level.
So those are, that could be any time from a month to a year later. That you
Oh,
find that
yes,
kind of
we're
stuff
still
out.
waiting
So,
on,
yeah.
yes. when we don't get the medical examiner's report in 6 months, well, when we don't get it in a certain amount of time, we re-request it. And then if it doesn't come after 6 months, Dr. Martin looks at it and we make a determination pending other information coming in.
Yeah, I guess just, you still may have a slight difference in numbers because if you look at the deaths in March and April, it's 17 and 17. Where here it's 15 and 10, so it's a difference of 2 and 7.
Well, and we don't always get to them in critical incident review right away.
Okay.
Is that what it is?
Okay, that could
I'll
be it.
ask.
Because
This
I
is
guess
numbers reviewed.
because if we're reviewing level 3s, 29 and 31 in those 2 months, still you're missing 4 in March and
It might have carried over to April. Our committee meets twice a month. I'll ask about that, though.
But you would reconcile some of that at the end of the year or something, or
I'll ask.
just as they come along, you reconcile with whatever you got?
Because we spend a lot of time on access to care with the performance improvement grid, and we're running short of time, can I just spend 5 minutes talking about?
Please do.
Thank you. Next month, we're going to review our standard monthly reports, but our focus is going to be on our quality management and quality improvement plan. This comes to this committee to be scrutinized and then presented to the board, hopefully approved for approval. Because it is a long document, I brought it to hand out to you today so that you would have time to read it and look at it. I cannot give it out to the public because it's not yet approved, so once it's approved by the board, then it will go on the website. But another thing that I would just like for you to consider as we are more familiar with the data, there are things in here that we might not see, such as our actual performance improvement projects, our initiatives, and our data regarding those. And as this committee gets more sophisticated at looking at the operations of Smoky, I would like for you to consider as you read this what else you might want to do in this committee other than just looking at this data where we're meeting our standards monthly. So.
Yeah, and you mean in terms of policies and procedures?
Or the data, for example.
Or looking at, or requesting different types of data?
Yes.
Okay.
If you look in here, you have a very rich source of our performance improvement initiatives. And for example, one of those performance improvement initiatives is, well, two of them are related to innovations, but one is do all innovations participants who show evidence of some kind of mental illness, have they been evaluated for that? And we found that's one we're just starting, so we're doing our baseline data, and I'm pretty sure it's kind of low, like 25%, if that. And so our performance improvement project is to make sure that any innovations participant, when the care managers review their records, if they see evidence of mental health, that when they look back in the record, there has actually been an assessment for a mental illness.
Yeah.
So things like that, you might want to look deeper at what we're doing than the performance measures that we hand into the state. That's just a thought I had and wanted to present to the group.
And that's a good idea.
So.
So I have within our own organization quality improvement team, I'd be, if you'll permit me, I'll have them look at some of this as well, particularly as we're talking about integration of primary care and public health.
Right, and the other thing that isn't in here yet, but that I'm working on, which has been just, you know my passion about ED admissions and discharges. We're doing a pilot project with our comprehensive providers,
Right.
and what we're doing is we're actually giving them the names of every one of their consumers who is admitted to the ED in a month, so that they can follow up on them and see what happened, that person went to the ED instead of coming to them as a provider when
Right.
they had a behavioral health crisis.
Right.
So that's one of our,
For the whole catchment area.
it's, we're doing that with our 5 comprehensive providers, and once we get that down and look at that, the admission, ED admissions and readmissions, then we hope to look at other providers who have high ED admission rates and work with them also.
So that's like Denmark, RHA, the ones that were here the other night, they're about
FPS.
Well, what would be really exciting is you look at the 50% who
Yeah.
have previously not been consumers of Smoky's care, if you could get back to their primary care physicians or to their other institutions that their organizations they're involved with, and see what could have been done in terms of preventing the crisis.
Right, catching
There may be low-hanging fruit there.
Right, and pretty
Also.
soon, hopefully in the, toward the effort of integrated care, hopefully when we start taking intake data, we will ask, do you have a primary care physician? Who is that primary care physician? And then we would be able to do that.
Yeah, that's terrific. That's great. How much time do we have to scrutinize this?
We're kind of
A month. Okay?
That's great.
Well, Julie, I sure appreciate it, and if there's any other business, we're kind of over time already, aren't we?
Yes, we always go over time.
Well, I just
That's because she provides us with such great data.
it's being
Her fault.
eternally optimistic. You always think you'll get more done than in the time you've got, so. I guess we need a motion to adjourn then? Second? Well, thank you all. All in favor? Aye. Well, I'm glad to be part of this. I hope I can be as productive as you all are, so.